Good afternoon, everyone. We're going to get started with our afternoon programming. So again, my name is Karen Fancher. I'm an associate professor of pharmacy practice at Duquesne University, and I have a clinical practice site at the University of Pittsburgh Medical Center, both in Pittsburgh, Pennsylvania. And again, it's an honor and a privilege to be here. I want to thank ASHP and ACCP for asking me back again to do my second favorite cancer, the lymphomas. So I had about 3 cups of coffee this morning, and I drank a Diet Coke at lunch. So good luck to you guys with keeping up with me in the next 75 minutes, because we got a lot of material to cover. So we will get started. There's our financial relationships. Here's the learning objectives. And this is kind of our table of contents. So we're going to spend the first part of the lecture on non-Hodgkin's lymphoma, and there's many different kinds of those. So we will cover indolent, diffuse large B-cell, mantle cell, Burkitt's, and then very briefly touch on the T-cell lymphomas. Then we'll switch gears and talk about Hodgkin's lymphoma. And in the handout only is Waldenstrom's macroglobulinemia. All right, so leading things off with non-Hodgkin's lymphoma. There's about 100 different kinds of lymphoma, everybody, and so one of them is called Hodgkin's. The other 99 are called non-Hodgkin's. Most of the non-Hodgkin's ones are B-cell, so we will do those first. So we'll start with a case. We have a 67-year-old male with newly diagnosed symptomatic follicular lymphoma. He has stage 3, grade 2 disease. He has no significant pertinent medical history. So which of the following would be the most appropriate treatment option for him at this time? Is it A, radiotherapy, B, BR for 6 cycles, obinutuzumab times 12 cycles, or CHOP times 8 cycles? So is that open? Are you guys able to answer that? Okay, good. All right, so I'm not able to see a count on the screen, so I'm going to close the poll here. Oh, you did answer. Okay, well, obviously we can't see that. So show of hands, how many people think radiotherapy? 1 or 2. All right, very good. How many people would vote for BR for 6 cycles? All right, large majority. Obinutuzumab times 12, any takers? No? All right, and CHOP times 8? Nobody. All right, very good. So many choices here. Of the choices that I gave you, the most appropriate is BR times 6. Okay, so we're in the B-cell space, so you would want to see something that includes an anti-CD20 monoclonal antibody, so the CHOP alone would not be appropriate. And this patient has a larger disease burden and would not qualify for radiotherapy alone. All right, so starting off with indolent or low-grade non-Hodgkin's lymphoma, our prototype disease of this subtype is going to be follicular lymphoma. This is extremely common in lymphoma land, and it's usually a disease of the elderly. So again, you can see our median age of diagnosis is about 70 years of age. Indolent lymphoma is incurable. So again, our focus here is not to cure these patients, but it's on palliation, management of symptoms, quality of life, and essentially, again, in an elderly patient population, to keep them alive long enough so that some other comorbid condition is the problem, right? So many patients in an indolent lymphoma may not need to be treated at all. So this is just a list of some reasons that you would begin therapy. Again, these are going to be patients that have symptoms, that have organ dysfunction as a direct result of their lymphoma, patients that prefer to intervene, and then any other condition like an autoimmune cytopenia or what have you. So on an exam, I don't expect that you would be asked to determine if a patient should begin therapy. I think you'll be told that they will be, but again, be aware there are some patients that we could just do active surveillance, and that would be appropriate. So for a patient who is going to proceed with therapy, we would stratify them into several different groups. One of the key pieces of information is what stage they are And then for follicular lymphoma or indolent lymphoma, you are also interested in what grade that their disease is. So you would need both pieces of information. The grade, in a simplistic standpoint, is basically like how ugly does that look under the microscope, right? With 1 being fairly non-threatening and 3 being very angry, and you probably want to intervene on that. All right, so again, you would never be asked to grade a patient's lymphoma, but what treatment you choose, you need to know that information. So we would divide this into stage 1 and stage 2 contiguous disease, and then grade 1 and 2. Stage 2 non-contiguous disease, so 2 separate sites of the body that could not be encompassed in a single radiation field, grade 1 or 2. Stage 3 and 4, also grade 1 and 2, and then any stage of disease in grade 3A or 3B, the really nasty ones. All right, so looking at each of these individually. Stage 1 or stage 2 contiguous and grade 1 or 2, in my mind this is like best case scenario, right? If you're going to intervene, we could actually do radiotherapy alone. So no pharmacy involvement here. I highly doubt that'll be a question. For stage 2, non-contiguous disease, but still grade 1 or 2, again, this is an area of controversy. We could argue all day long whether an anti-CD20 monoclonal antibody can be used alone. Should we start traditional chemotherapy? Might the patient receive some radiation? So again, I doubt that that would be a question because there are so many options. What is much more likely to be a question is a patient with stage 3 or 4 disease, but still grade 1 or 2. You got a lot of choices here. Okay, so what you should note, all of the regimens, all of the regimens actually, contain an anti-CD20 monoclonal antibody. And we are using in 2024 rituximab or obinutuzumab. All right, the days of ofatumumab have gone away. Some type of traditional chemotherapy, typically alkylating agent based, so bendamustine, CHOP, or CVP. And then we have a couple like lesser intensity regimens there at the bottom. So any of these would be appropriate for stage 3 or 4, grade 1 and 2. All right, so let's take a look here. So we mentioned 2 very reasonable options would be bendamustine and rituximab, or everybody's old friend, R-CHOP. So these have actually been compared to each other in follicular lymphoma with lower grade indolent or mantle cell lymphoma in a non-inferiority trial. And this was done quite a while ago, so we actually have long-term follow-up here. So in terms of progression-free survival, highly in favor of bendamustine and rituximab. Likewise, for the time to next treatment, how long does the patient remain in remission, also in favor of BR. And notice here that we have 10-year overall survival data, right? So this tells you that indolent patients live a long time no matter what you intervene with. And R-CHOP was obviously more toxic in terms of neutropenia. So what that means is BR is an acceptable regimen or an acceptable substitution for the traditional R-CHOP you think about with non-Hodgkin's lymphoma, especially in an older patient, a frailer patient, someone who won't tolerate neutropenia very well. Newer in the non-Hodgkin's lymphoma space is obinutuzumab, the glycoengineered CD20 monoclonal antibody. So I tell my students, this is like souped up rituximab, right? Or like rituximab on crack, right? So we compared the use of obinutuzumab to the use of rituximab in a very large study called Gallium. So in this study, the investigators got to pick the chemotherapy backbone. So they got to pick CHOP, CVP, or bendamustine, and then the patients were randomized to either rituximab or obinutuzumab, with a primary endpoint of progression-free survival. So here's the results of those, and in summary, they tended to favor the G chemo, so G being the brand name of obinutuzumab, tended to favor those results. However, there were a greater incidence of infusion-related reactions and infections noted in the obinutuzumab-containing arms. So a trade-off of potentially greater efficacy but greater toxicity in an elderly patient population. Also, in that trial, there were more deaths in patients that received the bendamustine-containing regimens, either BR or BO, bendamustine and obinutuzumab, regardless of infections or what the cause of death was. Okay, so a little bit of like, why did that happen? I just told you bendamustine's probably a safer regimen. So what this leads us to is that any of those combinations are realistic choices. It's going to depend on the patient and their comorbid conditions and what your institution prefers. We also have in this space a chemotherapy-free option. So this is a regimen of lenalidomide and rituximab that was studied in a study called Relevance. So a very large study, over 1,000 patients with untreated follicular lymphoma, and they were randomized to either lenalidomide and rituximab, which we call R-squared, or chemotherapy plus rituximab. And again, the investigator chose the chemotherapy backbone here. So thinking back to the statistics lecture yesterday, this was a very questionable trial design. So they designed the trial as a superiority trial and had two primary endpoints. So unfortunately, the trial did not meet its primary endpoints of superiority. So here you can see there was minimal difference between the treatment arms, definitely not a difference including superiority. So we now use this as a Category 2A recommendation for follicular lymphoma in the frontline setting. And again, the advantage here is it's quote-unquote chemotherapy-free. Okay? You do have to rely on the patients to take an oral drug at home, and it has its own kind of perks of side effects, but it is listed in the guidelines. Okay, now what about a patient who is any stage but grade 3A or 3B? So the magic word you can see on this slide is controversy. All right, there's a lot of arguing about whether 3A and 3B are actually different, if they should be treated different than a grade 1 or 2. Some references suggest a 3B, you should treat them like diffuse large B-cell lymphoma. So I don't think that this is a fair question at all. I think the bulk of the questions in this area would come out of a grade 1 or 2 patient. All right, so this is just a summary slide. For follicular lymphoma in the first line setting, stage 1 or stage 2 contiguous, grade 1, no drugs, radiotherapy. Stage 2 non-contiguous, grade 1 or 2, any number of options, monoclonal antibody, chemo, radiation, all of the above. For stage 3 and 4, again, grade 1 and 2, you have many options, including one of chemotherapy-free, lenalidomide and rituximab. And grades 3A and 3B are controversial, so I doubt you would see a question about that. All right, so now, the same patient completed 6 cycles of BR and achieved a complete response. He asks if he's a candidate for maintenance therapy. So which of the following is the most appropriate response to his question? A, yes, he should receive rituximab every 2 months for 2 years. B, yes, he should receive lenalidomide daily for 3 years. C, yes, he should receive obinutuzumab monthly for 1 year. Or D, no, maintenance therapy is not indicated in follicular lymphoma. All right, so again, show of hands. He should receive rituximab every 2 months for 2 years. Okay, most of the room. He should receive lenalidomide daily for 3 years. Oh, that was Dr. Moore this morning, right? Myeloma, not lymphoma. Good. He should receive obinutuzumab monthly for 1 year. Nobody. Very good. Because he got a Rituxan-based regimen, he should continue on Rituxan maintenance. Very nice. And that means D is incorrect because he needs maintenance therapy. Excellent. So the role of maintenance therapy was cemented in a trial called PRIMA. Again, this is a landmark trial, so very briefly, a large trial of patients with untreated follicular lymphoma who received chemotherapy. All the regimens contained rituximab. They were then re-randomized to either Rituxan maintenance or observation. And the results are shown for you here. Again, long-term follow-up data. We have 10-year progression-free survival data. The patients that received Rituxan maintenance had a longer progression-free survival and a longer time to the next treatment. There was no difference in overall survival, but again, in an incurable malignancy, maybe that's not your end game, right? So again, this is currently a recommendation for patients who respond to first-line chemoimmunotherapy. So if they have a complete or partial response, they should move into some maintenance therapy. For a Rituxan-based regimen, you would continue rituximab in maintenance. And for a patient who received obinutuzumab in their initial regimen, you could do obinutuzumab maintenance. All right, again, that's from the Gallium study and others that I did not show you here. As I mentioned, indolent lymphoma is incurable, so every patient will relapse and need additional therapy if they are still in good enough shape to do so. All right, so what can we do at that point? Still a lot of options. You could mix and match based on what their initial regimen was. You can see here we can get down into single agents like obinutuzumab and rituximab if the patient had become very frail. And if the patient completed that therapy and got a complete or partial response, you could do second-line maintenance therapy down at the bottom. So what's really become interesting in the follicular lymphoma space is the third-line treatment options. So under our PI3K inhibitors, the only one that is left standing in follicular lymphoma is copanlisib. The other two, idelalisib and durvalumab, have actually had their indications withdrawn due to a lack of efficacy data. Here's where we could start to use some CAR T therapy. We could use tazemetostat. But the newest agent here is actually a bispecific T-cell engager called mosunetuzumab, which we'll talk about here momentarily. So again, this is a bispecific agent, or I know them as BITE, you guys, B-I-T-E, bispecific T-cell engager. And if you have heard Dr. Parasinati's podcasts, they actually refer to this as Tinder for T-cells, right? Let's meet up, your B-cells and T-cells together, see what happens. So this was approved in December of 2022 for relapsed or refractory follicular lymphoma after 2 or more lines of therapy. And the approval was based on a very small phase 2 trial. Remember, though, these patients are going to be very heavily pretreated. So they saw a very impressive complete response rate, and their median duration of complete response, progression-free survival, and overall survival were not able to be estimated. So that is impressive data for a heavily treated patient population. So this agent, as a monoclonal antibody, but also one that interferes with T-cell function, is going to have a risk of cytokine release syndrome. So the package insert advocates for what's called step-up dosing, where we actually build the dose up to the full dose over time. The patients need pre-medications that I have spelled out for you here and in your handout. They're required for cycles 1 and 2, but in my personal opinion, I would do that for every cycle. If the patient has a response, we can end therapy after 8 cycles. But if the patient only has a partial response or stable disease, the indication is actually for 17 cycles. And a big point here, hospitalization during dosing is not required. So in theory, this agent could be given as an outpatient. All right, we're going to talk about some other drugs in this same class where hospitalization is actually required, so kind of a difference here in terms of practice styles. Adverse reaction-wise, again, cytokine release syndrome, there's a boxed warning for that, as well as neurologic toxicities that you would see with other agents that work in a similar way, and some other common toxicities like fatigue and rash and such. All right, so we're going to switch gears, and we're going to have a question about diffuse large B-cell lymphoma now. So we have a 63-year-old male who was recently diagnosed with stage 4B, diffuse large B-cell lymphoma, without a rearrangement in BCL2, BCL6, or MYC. He has 5 areas of lymphadenopathy, and his IPI score is 3. So which of the following would be the most appropriate treatment for him at this time? And I'll read the answers, and then we can switch here. So R-CHOP times 3 plus radiation therapy, R-ICE times 3, POLA-R-CHP times 6, or G-CHOP times 6. All right, well, since you can't vote this way, we can do hands. All right, so R-CHOP times 3 plus radiation therapy. Good. All right, it's a very small number. The patient has stage 4B disease, so the patient needs more than 3 cycles. All right, good. What was R-ICE times 3? All right, nobody, good, because R-ICE is a salvage regimen, not a lead-off regimen. POLA-R-CHP times 6. Yes, if anybody follows lymphoma news, POLA-R-CHP's like our hot new toy, right? Or I call it our shiny new object, woo, right? And then G-CHOP times 6. Anybody? Good thought. But in diffuse large B-cell lymphoma, there is no obinutuzumab. Okay, there are some studies that have actually had negative results, so in that case, we would not do that. All right, very nice work. Oh, look, there's the answers. Good job, everybody, good job. Okay, so now let's talk about diffuse large B-cell lymphoma. Again, this is kind of the classic lymphoma here. Your goal is much different than follicular lymphoma. Follicular lymphoma, we said you're gonna quality of life, keep those patients comfortable for as long as possible. Diffuse large B-cell lymphoma is curable, so you are going for it in the majority of patients. There's a lot of interest lately in what's called the cell of origin. So B cells arise out of either an activated B cell or a germinal center B cell, and there's some hint that that difference may influence response to therapy. Okay, so there's some hints that the germinal center does better with conventional chemotherapy, and maybe it's the activated B cell type that needs a more aggressive regimen. But notice the last bullet point here. This does not influence treatment at this time. I don't believe that's going to be a question. Maybe next year I'll have more information for you. So for newly diagnosed patients, again, we're going to stratify them into several different groups. Stage 1 and 2, non-bulky. Stage 1 and 2, bulky. Or stage 2 with extensive mesenteric disease, or any stage 3 and 4. So just a quick little history lesson. When we developed the CHOP regimen, that revolutionized the treatment of lymphoma, and then we came along with rituximab and increased our survival numbers even more. So again, the backbone for the last 25 years has been our CHOP. But in the last year or two, we're starting to have the up-and-comer POLA-R-CHP. So we'll point out its place in therapy here. So as a reminder, there's no obinutuzumab in diffuse large B-cell lymphoma, and there is also no role for maintenance rituximab after the completion of initial therapy. So if you see that on a test question, that is a trick. Be careful, it's false. All right, so if the patient has very limited disease, stage 1 and 2, non-bulky, you could do R-CHOP, either 4 or up to 6 cycles. And this is based on a study called FLYER, which I did not include in the slides, but is detailed in your handout. When I made these slides, the recommendation for stage 1 and 2 bulky disease was R-CHOP times 6, plus or minus radiation, which you would never make that decision as a pharmacist about the radiation. But in their most recent guidelines, less than 2 weeks ago, NCCN actually included POLA-R-CHP for stage 1 and 2 bulky disease with a high IPI score, International Prognostic Index. So leave yourself a little note to go back and look at that in the guidelines. For a more advanced disease, stage 2 with extensive mesenteric involvement, or stage 3 and 4, again, category 1 recommendation for the last 25 years has been R-CHOP times 6, but new in the last 15 months or so, POLA-R-CHP times 6 cycles for patients with a high IPI score, or International Prognostic Index. Okay, again, I don't expect that you would be asked to calculate that, but that is certainly a fair answer in the most recent guidelines. All right, so reviewing the data here for polatuzumab vedotin. So we modified the CHOP regimen by dropping the vincristine, so dropping the O, and replacing it with polatuzumab vedotin, and then rearranging all the letters, now calling it Pola-R-CHP. All right, so this trial was called POLARIX, where we compared Pola-R-CHP to R-CHOP in about 900 patients with previously untreated intermediate or high-risk diffuse large B-cell lymphoma. So again, those higher IPI scores. So this is the short-term data. So progression-free survival favored the Pola-R-CHP, as well as what the time to next treatment for their subsequent treatment of lymphoma. In this data, no difference in overall survival. All right. Most recently, we do believe that there might be a difference in overall survival, but the data is very immature. NCCN, though, is convinced of its superiority. So now we have a Category 1 recommendation in the first-line treatment for stage 2 with extensive mesenteric disease, or stage 3 or 4 to any diffuse large B-cell lymphoma. And again, the caveat here was that they have a higher IPI score. I understand the rationale for including this particular agent, but polatuzumab is also used in later lines of therapy, so that kind of makes us wonder, are we burning an agent too quickly? Okay, we don't have that answer, but that's what makes me wonder that clinically. There's also some subgroup analyses that suggest maybe this is a good regimen for patients that have that non-germinal B center cell of origin, but again, we do not make treatment decisions based on that at this time. All right, now what about elderly patients? So there's many options here. I have them all detailed in your handout, but I cherry-picked a couple to show you here. So again, an elderly patient, we're probably worried about cardiac function, ejection fraction, so maybe I would need to be concerned about the anthracycline. So we have a couple R-CHOP knockoffs here where we have substituted other drugs for the anthracycline. Likewise, we could use regimens where we do not escalate the dose of anthracyclines. For a very elderly patient, you can use what's called mini CHOPs. So again, the doses, but at much smaller doses and much less intense. So again, this is all detailed for you in your handout, but just to let you know that we do not expect an elderly patient to tolerate full doses of R-CHOP or Pola-R-CHP very well. All right, what about the flip side? What if you have a very young patient that you are very interested in being aggressive and potentially can we intensify the dose? So we have tried that in many different formats. So one possibility is to maintain the dose intensity of the anthracycline. Another possibility is to escalate the doses and use an infusional schedule, as in dose-adjusted or EPOC. We have played around with shortening the interval, so using every 14 days instead of every 21 days for R-CHOP. And then I kind of made up this last bullet point here, R-CHOP plus X, right? That's my lingo, but that's R-CHOP plus something else. Lenalidomide, bortezomib, ibrutinib, venetoclax, what have you. All right. None of these have borne out as a option for most patients. Okay, there is maybe one exception, but in the big picture here is that changing the dose intensity has not proven to be successful in terms of efficacy, but it certainly increased adverse effects. All right, so the study I will highlight for you here, this is the CALGB or Alliance trial. This was a trial of R-CHOP versus dose-adjusted R-EPOC, and a primary endpoint of event-free survival, but of course we were interested in overall survival and safety with a more intense regimen like EPOC. And what you can see here is there was no difference in overall response rate, progression-free survival, or overall survival, but our EPOC regimen was clearly more toxic, right? There were more patients that discontinued treatment, that had febrile neutropenia, that had long-term issues with peripheral neuropathy. And the subgroup analysis did not reveal a difference for any group either, right? So because of that, in the guidelines right now, dose-adjusted R-EPOCH is a Category 2A recommendation for most patients with diffuse large B-cell lymphoma. I'm hinting at maybe there is a subset of patients that this could be the preferred regimen. And that is a group of patients called high-grade B-cell lymphoma, or what you might know as double hit, right? So we look at several genes when we're making the diagnosis of diffuse large B-cell lymphoma. We can look at the MYC region, which is an oncogene, and we can look at BCL2 and BCL6, which are tumor suppressor genes. So if you have rearrangements in at least 2 of those, you can start cell division, but you can't stop it. So that seems like a more aggressive type of tumor. So any rearrangement in MYC plus any rearrangement in BCL2 or BCL6 is called double hit, and all 3 would be triple hit. All right, and any of these rearrangements, we know these patients have a poor clinical outcome, and their disease is usually very angry. These are the ones with proliferation index like 99 out of 100. Right? So those are the patients that perhaps are the best candidates for dose-adjusted R-EPOCH. All right, but I said perhaps, right? The guidelines do not call out a particular regimen. They just kind of hint that you may want to think about a more intense strategy for a patient that is known to be double or triple hit. We also have to talk about potential central nervous system involvement in diffuse large B-cell lymphoma. So in diffuse large B-cell lymphoma, the risk of CNS involvement is low, but it's not 0. So we do need to consider that. There is an IPI score specific for central nervous system involvement, so that's called the CNS IPI score. And again, depending on the patient's score, you may choose to intervene with some type of CNS-directed therapy. So you could use intrathecal methotrexate, systemic methotrexate, or cytarabine for prophylaxis. If you actually documented CNS involvement, again, we would use systemic plus or minus intrathecal methotrexate or cytarabine. So again, I don't expect a question that should this patient receive CNS prophylaxis or not. I think the question would be, we have documented CNS involvement of diffuse large B-cell lymphoma. What do you want to do about that? You need to add some additional agents because R-CHOP and POLA-R-CHP will not cross your blood-brain barrier. All right, so about 60% of patients, or maybe more, will be cured with our initial intervention, but some patients are going to relapse or be refractory to that. These patients are still potentially curable, so that's great news. And very recently, we have changed the way we approach relapse and refractory disease in diffuse large B-cell lymphoma. So now we think about, when did their relapse occur? If it occurred more than 12 months after they finished their initial treatment, that's one possibility. Second possibility is they relapsed less than 12 months after completing their therapy, or they never had a response at all. So that would be called primary refractory. So in my mind, this is you had a long response versus a short response. So we will refer to it as that. So if you had a long response, which we're going to define as more than 12 months after you completed your therapy, we would then consider if you are eligible for a transplant, an autologous stem cell transplant. So if you are, we would do any number of preparatory regimens like R-ICE, R-ESHAP, R-DHAP, and then proceed to a transplant if you had a complete response. If you did not, this is where we would consider CAR T therapy. And I have the agents listed for you here that are approved for this scenario. If you had a long response, but we're never going to have a transplant, you are not a candidate or you refuse, again, many options to choose from. Here's again where we see polatuzumab, we see some other monoclonal antibodies, tafasitamab and what have you, all detailed in your handout. But point to be taken here, these patients still have a lot of options. If your response was very short, so you relapsed less than 12 months after you completed your therapy, or you never had a response, if you were primary refractory, here's where we're starting to see the CAR T products. All right, these are now technically second-line therapy in diffuse large B-cell lymphoma. So those are a big change for us. So the ones that are FDA approved are axicabtagene and lysocabtagene. These are based on Zuma trial and Transform trial, again, which I have detailed in your handout for you. But they would both be appropriate in this setting. All right, what about third-line therapy? If you were not cured after your first or second attempt, any CAR T product would be appropriate if you had not yet received it. Again, other monoclonal antibodies like loncastuximab. We could use selinexor, which you heard in the myeloma space today. But new in this area is those bispecific T-cell engagers, but now for diffuse large B-cell lymphoma. So this is epcoritamab and glofitamab, which are indicated for 2 or more lines of systemic therapy after transplant or CAR T. So you would have had to receive one or both of those first. So these 2 drugs were approved within several weeks of each other, so I kind of laid them out like side by side. So these are their approvals, most of them for diffuse large B-cell lymphoma, whether it came from a high grade or an indolent or what have you. But NCCN says both of them or either of them can be used after 2 or more lines of systemic therapy. Here's a comparison of their efficacy. Again, I know we're doing a cross-trial comparison here, but they're pretty close in terms of efficacy. They both have that step-up dosing where we start very small and work up to the final dose. But notice that they both require hospitalization when you get to the first dose of the full amount. Epcoritamab is administered subcutaneously forever, right? Glofitamab is administered intravenously and is actually approved in combination with obinutuzumab. So now we need to add additional agents, but the trade-off is it's finite dosing. All right, so again, I would circle back to this slide and make sure you understand the differences between the products, but also what would be required for the patient. When do they need to be hospitalized? Do they need a second drug? How long will this therapy last? I think those are all very reasonable questions. All right, both agents have a box warning for cytokine release syndrome and require pre-medications. We can see an incidence of ICANS that you heard about in the acute leukemias module, and again, some other common adverse effects, including musculoskeletal pain and fatigue. All right, very briefly, I wanted to mention there is a subcutaneous form of rituximab called Rituxan Hycela. It's approved for both CLL and lymphomas. You should definitely make a note to circle back to this one because the dose is different based on which disease you're using it in. So that seems like a kind of tricky little point there. And the NCCN guidelines say that you could use this product after the patient has tolerated 1 dose of intravenous rituximab. Likewise, during the management section this morning, we heard about biosimilars. There are at least 3 rituximab biosimilars right now. FDA says they are not interchangeable, but the NCCN guidelines says any of them are appropriate for use. Now we're going to move into mantle cell lymphoma. All right, so we have a 72-year-old male who was initially treated with VR-CAP and achieved a remission for 15 months. He was recently found to have relapsed disease, and he's a candidate for further treatment, but he still has residual peripheral neuropathies from the previous chemo that inhibit his activities of daily living. Based on this information, which of the following is the most appropriate treatment? Is it acalabrutinib and obinutuzumab, bortezomib and rituximab, brexucabtagene autoleucel, or zanubrutinib? All right, I'll close the poll here. Okay, interesting. All right, so I would argue against bortezomib and rituximab because the patient has told you he has peripheral neuropathies, and we heard this morning that bortezomib is pretty famous for that. All right, brexdecabtagene is the CAR T product for mantle cell lymphoma, but it is not appropriate unless it is greater than the second line, so this patient isn't there yet. You guys are probably like, my God, Karen, stop talking about the Bruton's tyrosine kinase inhibitors, right? But this is a big deal in mantle cell lymphoma as well. But in this space, they are used as single agents. So the most appropriate answer here is zanubrutinib. So a little background on mantle cell lymphoma. This is much rarer than follicular or diffuse large B cell. In my mind, you guys, this is like the worst case scenario. It's technically classified as an indolent lymphoma, but it behaves like an aggressive one or even a little more than that. So in most patients, this disease is very hard to control. And we're also talking about an elderly patient population that may not be able to tolerate very aggressive therapy. So once again, we would break these patients down based on their stage. The best case scenario would be stage 1 or contiguous stage 2, non-bulky. I have never seen that. All right, I feel like, again, these patients are like leprechauns. Like, oh, I think there might be some out there, but I've never seen one. So technically, if that occurs, you could do radiation alone or add radiation to chemotherapy. Not a common scenario. Moving up into higher stages, now we're talking about chemoimmunotherapy. But again, in stage 2, bulky disease, and stage 3 and 4, you need to think very carefully about that patient's comorbid conditions. And if they get through your first choice of therapy, we need to do an extended consolidation given the disease's propensity to recur. So if you had a younger mantle cell lymphoma patient that did qualify for aggressive induction therapy, there are quite a few choices here, so many that they don't even have like an abbreviation, they just go by a name like Nordic or Triangle. I have them all detailed in the handout, but these are basically R-CHOP plus more stuff. All right, so again, this would be very difficult to tolerate in an elderly patient population. If the patient got through whatever your choice was and achieved a complete response, you would move into 2 years of a Bruton's tyrosine kinase inhibitor like ibrutinib or acalabrutinib or zanubrutinib, and do rituximab maintenance therapy like we saw in the follicular lymphoma population. Most patients are going to be on the less aggressive induction pathway, so again, you should recognize these regimens, BR and R-CHOP. VR-CAP is a knockoff of R-CHOP. We're now substituting bortezomib for vincristine there. So if the patient gets through those and achieves a complete response, you could do rituximab maintenance if they got R-CHOP or BR, but the other regimens have not been tested for maintenance therapy. In clinical practice, we tend to do it anyway. But again, I think this slide is much more real world, right? These are usually the patients we see with mantle cell. Unfortunately, disease relapse is almost 100% in these patients. Most of the patients at this point will choose an oral Bruton's tyrosine kinase inhibitor, so acalabrutinib, zanubrutinib, and there is still a mention of ibrutinib in the guidelines, which is very interesting given that the FDA approval for ibrutinib in mantle cell was recently withdrawn. So it's in the guidelines, but is no longer indicated by the FDA. So in clinical practice, we usually just pick acala or zanubrutinib. There are even other choices in the relapse setting, but the new one here that we're very interested in is what we talked about yesterday, pirtobrutinib. So this is the non-covalent or reversible Bruton's tyrosine kinase inhibitor that has been approved actually for 2 different indications, and its first one was in relapsed and refractory mantle cell. This was from the same study that we discussed yesterday in CLL. So this study was called Bruin, had multiple B-cell malignancies. So on this slide, I have teased out the mantle cell patients. And again, the overall response rate was pretty good for a heavily pretreated patient population including patients that had previously received a covalent Bruton's tyrosine kinase inhibitor. Once a day dosing, and again, our experience so far has been the drug is pretty tolerated, or pretty well tolerated. What I find interesting is that it has a lot of drug interactions, but when you read how to manage that in the prescribing information, they actually refer you to the other medications prescribing information. So I have that underlined here. If you have an interaction with diltiazem, the package insert says go to the diltiazem prescribing information, like they punt it to some other information. Again, you as pharmacists should be able to figure that out, but that's the first time I've ever seen them refer like, oh yeah, don't look in my package insert, go over there. All right, finishing up in our B-cell lymphomas. We have a couple slides here about Burkitt's lymphoma, which is a very aggressive B-cell lymphoma. Some references call it the most rapidly dividing tumor on Earth. There are several different forms. You may be familiar with the endemic form in sub-Saharan Africa. The slides here are about adult, non-endemic Burkitt's lymphoma. This is a true medical or oncologic emergency. Patients will die within weeks if we don't intervene. Because it's so rapidly dividing, your goal is to cure these patients. But because it's so rapidly dividing, R-CHOP is not enough. You're going to need more than that. Okay, we could argue all day long about what is more than R-CHOP, so I have some examples for you here. If you are low-risk Burkitt's lymphoma, and I don't even know what that means, right? How can you be low-risk Burkitt's? But if you are, there's some examples here. You can appreciate how many chemotherapy agents are in each of those regimens. If you are high risk, it's even more of that. Now we're adding in additional arms, so Codox alternating with IVAC and what have you. And Burkitt's lymphoma loves your brain, folks, so you have to add intrathecal treatment in every patient. So for Burkitt's, that is a part of the standard of care. These patients are at high risk of tumor lysis syndrome, so we could consider several days or weeks of pre-phase therapy with steroids and rituximab to try to decrease the tumor burden before we initiate whatever's at the top of that slide. For relapsed Burkitt's, you guys, my mentor used to say, Burkitt's is one and done. You get one shot at this, and if you get it right, the patient is done in a great way. They're going to be cured. But if we don't do it right the first time, we're done in the opposite direction, right? So again, this is when NCCN says your first line or first choice is a clinical trial, you know you're in a world of hurt, right? So there's very limited data with these other regimens I have listed here. But again, one and done, you want to do it right the first time with one of the agents on the previous slide. All right, now we're just going to do a few minutes of the T-cell lymphomas. So we have a 67-year-old female with refractory cutaneous T-cell lymphoma. She has tried numerous topical and systemic therapies over the last 6 years. Which of the following supportive care issues is a frequent consideration in the treatment of patients with this type of lymphoma? Is it bleomycin-induced pulmonary toxicity, hepatitis B reactivation, pruritus, or mucositis? All right, let's take a look here. All right, very good, very good. So the correct answer here is C, pruritus or itching. I'm guessing those of you that chose that have actually seen a patient with cutaneous T-cell lymphoma. These patients just suffer, you guys, from the skin involvement. They're just terribly, terribly depleting of your quality of life. Bleomycin is not used in the treatment of T-cell lymphoma, so that's not it. Likewise, we do not use rituximab since it's a T-cell disease, so there's not as heavy of a concern as hepatitis, and I just kind of made up the mucositis one. All right, so cutaneous T-cell lymphoma, there are many different subtypes. The most common ones are called mycosis fungoides or Sézary syndrome. These are separated into early stage disease and later stage or extensive disease. I have spent many hours preparing tables in your handout of which agents and their response rates and all kinds of things. But these are usually treated at specialty centers. I don't think it's a fair question to ask you how these patients would be treated. What I think is a fair question is how you are going to manage these patients' complications. All right? As I mentioned, pruritus or itching is very common, very depleting of patients' quality of life, so I have some treatments for you there. These patients usually have some sort of psychiatric adjustment disorder because of their effects on their appearance and, again, the quality of life issues. So you would think very carefully about a referral for that. And because of skin breakdown, these patients are at high risk of infection. So I have some management strategies for you here, including prophylaxis against HSV and VZV. And because an advanced disease, the tumors can actually become necrotic in the skin, you have to think about both gram-positive and gram-negative coverage. All right, and finally, peripheral T-cell lymphoma. This is relatively uncommon. This is only about 10% of lymphoma cases. Despite it being uncommon, there are 27 different subtypes, with the most common being called not otherwise specified. You know, that's super helpful. So what you should remember here is that you cannot use rituximab. There is no B cell. There's a T cell problem. So inherently, the response rates are going to be less because we know the benefit of rituximab in B cell malignancies. We still use anthracyclines, so CHOP, EPOC may be appropriate here. Very recently, we tried to add romidepsin, and that was unsuccessful. As I mentioned, there's no rituximab here. Very rarely, you may come across a peripheral T-cell lymphoma patient that is CD30 positive, and the drug for that is brentuximab. So if you found that patient, there's actually data to support that, but you would need to confirm that they are CD30 positive. When these patients relapse, it's like, roulette wheel of choices here. I have some possibilities that are listed here. Again, response rates are all over the place, but what you should note is that the progression-free survival is extremely short in the second-line setting, and you would be thinking about referral for a transplant in these patients. Okay, so that is our discussion about non-Hodgkin's lymphoma. All right, let's finish up Hodgkin's. We have a 31-year-old female with a history of type 1 diabetes, iron deficiency anemia, and dysmenorrhea. She has newly diagnosed stage 2B, bulky, classical Hodgkin's lymphoma. Which of the following is the most appropriate initial therapy for this patient? Involves site radiation, ABVD, brentuximab vedotin, or Stanford 5? All right, let's take a look here. Very good. So nobody was distracted by Stanford 5. I should probably change that. That's not even a recommended regimen for Hodgkin's anymore, so you guys got me there. This patient has stage 2B bulky disease, so radiation alone would probably not be enough. And in the frontline setting, we do not use brentuximab vedotin alone. So I know what you guys were thinking when you picked that, but it is not approved for us, or it's not indicated for single agent in the frontline setting. So of the choices I gave you here, ABVD is probably the most appropriate. All right, so I told you guys my favorite cancer type is CML, true, but my second favorite is Hodgkin's, because again, I love cancers you can cure. You guys, I love cancers with a happy ending. And based on this slide, we're gonna get that in the majority of patients. So your goal for every patient is cure. So many patients are going to be cured that we actually have to think about long-term toxicities of the chemo because we expect these patients, and especially a younger one, to have a normal lifespan. So these are good problems to have. In Hodgkin's, there's only two types, classical and nodular lymphocyte predominant. So classical is the one you learned about with the Reed-Sternberg cells with the 2 giant nucleoli and what have you. There's technically 4 subtypes of that, but we don't care. We treat it based on stage. That's it. Right? Nodular lymphocyte predominant is its own little thing. It's its own unique entity because that type of lymphoma does not have those Reed-Sternberg cells, but they are typically CD20 positive. So that's the only reason you would use rituximab in a patient with Hodgkin's disease. There's a hint. All right, so the treatment is currently based on what stage the patient is and then their age. So if they're between the ages of 18 and 60, that's one possibility. And if they're greater than 60 or are compromised in some way by performance status or comorbidities, they're treated differently. All right, so the backbone of Hodgkin's disease for many years has been ABVD. But again, there's some long-term toxicities, specifically with the bleomycin component. So what we're doing now in 2024 for one option is leading off with ABVD, but then dropping the bleomycin or adjusting what's left after the first 2 cycles. All right, so again, this is detailed in your handout, but we would get imaging after 2 cycles. It's called a Deauville score, and based on the score, you could de-escalate therapy, drop the bleomycin. You could continue the same therapy, or worst case scenario, if you didn't make any progress in those first 2 cycles, you could actually escalate further therapy. So I'll show you some examples here. But the reason we do this is to avoid the long-term toxicities, as I mentioned, pulmonary toxicity, but also for a younger patient, you would want to try to preserve fertility and avoid secondary malignancies. All right, so here's some examples that I created. I am not an artist, so everybody give me a little bit of grace here. So this would be stage 1A and 2A, favorable disease, non-bulky disease, and young, between 18 and 60. You would lead off with ABVD for 2 cycles. You would do some imaging. If the imaging was favorable, you could potentially drop to just radiation. You could do 1 more cycle of ABVD. You could drop the bleomycin and do AVD. So again, and worst case scenario, you didn't make any progress. Let's rebiopsy that and see if this is really Hodgkin's. But I don't expect you guys to interpret Deauville scores. I think what the thing to think about here is de-escalating therapy if the patient's showing you a good response. All right, very similar here for stage 1 and 2 unfavorable disease, younger patient. You're going to lead off with ABVD for 2 cycles, and then depending on the results of the imaging, drop the bleomycin or finish the therapy quickly. If the disease does not respond, you would escalate up to a more intensive regimen like BCOP. And finally, stage 3 and 4, you're going to lead off with ABVD for 2 cycles, do some imaging. If you have a good response, drop the bleomycin and finish out 6 cycles. If the patient did not respond, you're going to escalate to a more intensive regimen like BCOP. All right, but those of you that practice in this space are probably like, Karen, give brentuximab its due, right, which we certainly need to do. So also new, or newer, in the Hodgkin's space is the use of brentuximab vedotin in the frontline setting. So once again, playing with the regimen here to try to minimize toxicity. So we substituted bleomycin for brentuximab vedotin. The brand name of brentuximab actually starts with the letter A, so we call this new regimen AAVD, or A plus AVD. So A plus AVD was compared to ABVD in a study called Echelon 1. And we could argue all day long about their endpoint in this study. They used something called modified progression-free survival, where they included a non-complete response as a progression event. Okay, so they had some, like, what I will say, creative ways to classify an event of progression in this study. So this study has recently been updated. We got some 6-year overall survival data very recently. So in terms of progression-free survival, it favored the A plus AVD arm. All right, the 6-year overall survival, though, no difference. There was less pulmonary toxicity in the A plus AVD arm, but there was more peripheral neuropathy, and there was also more febrile neutropenia. So much so that they adjusted the study before it was finished to mandate that growth factors are used with A plus AVD. All right, so the summary here. Patients who received A plus AVD had statistically significantly increased modified progression-free survival at 2 and 5 years. However, this is at the expense of using colony-stimulating factors right up front and more neuropathy. There was less pulmonary toxicity. But probably the stickler in clinical practice is the cost. All right, the cost of A plus AVD plus growth factors is approximately 100 times the cost of ABVD. And that was studied without dropping the bleomycin. Okay, let's be very clear. In the Echelon 1 study, they did not adjust the therapy based on response. So lots of questions remain, but NCCN has said that brentuximab vedotin is a Category 1 recommendation in the A plus AVD regimen in stage 3 or 4. Contraindicated in patients that have baseline neuropathy because we saw that as a significant adverse event. So again, I think good patient selection is the key here. Okay. Is anybody doing this like a lot? You guys, everybody? I'm getting some okay, very good. All right. I mentioned a more intensive regimen called BCOP. This is what our European colleagues tend to use. In the United States, this is not the standard of care, mostly because we feel that it is too toxic. All right, there's a high incidence of myelosuppression and infections. Long term, we would worry about secondary malignancies from the procarbazine component of this regimen. But the guidelines would say you could consider it in a very high-risk patient, and I have some characteristics for you there. All right, what about an elderly patient or someone who is of poor performance status? These patients are still potentially curable, but we're not talking about a 90% success rate here. We're talking probably 70 or maybe less. You, again, need to be very thoughtful in your choice of regimens because an elderly patient with COPD probably should not receive bleomycin. Likewise, an elderly patient with significant peripheral neuropathies probably should not need receive brentuximab. So I have some examples listed for you in the handout. But I think the key word on this slide here is individualized, right? You need to be very thoughtful about an elderly patient because of toxicities. All right, now how about some supportive care things with ABVD? So I mentioned bleomycin and the pulmonary toxicity. This is pretty minimal in 2024 because, again, we are now adapting therapy based on responses on scans. However, it is still a possibility and is very significant. If anybody's ever seen a person develop bleomycin-induced pulmonary toxicity, that is irreversible. So we would certainly like to avoid that. All patients should get pulmonary function tests before we start and periodically during therapy. There's a rumor that this is associated with using growth factors with the ABVD regimen. Probably not true, but you might see that. And I didn't put it on the slides here, but here's a really good example of pharmacists getting involved with smoking cessation. If your patient is a smoker, here's a very good reason to stop or decrease that. Likewise, these patients are curable, so you should not be reducing the dose or holding doses or changing the schedule because of neutropenia. All right. Several studies have said you can just keep plowing through the ABVD without starting any growth factors. And again, that's ABVD without dropping the bleomycin for good response. So don't be afraid to keep going, you guys. The eye on the prize here is you're trying to cure these patients. For the few patients who are not cured from our initial therapy, now we're going to think about, are they a good candidate for a transplant or not? So again, you can still cure these patients. So when they relapse, if they do, we're going to think about whether they're a good candidate for an autologous stem cell transplant or not. If they're not going to a transplant, again, you have lots of options here in terms of chemotherapy regimens. If they had not yet received brentuximab, here's a good place to start that. And you could potentially now start introducing some checkpoint inhibitors, which I have on another slide. In the relapse setting, there's a pretty landmark trial called ATHERA, which showed the brentuximab vedotin's role in the relapse setting. So this was a phase 3 trial where patients received planned brentuximab after their stem cell transplant. All right, so these were patients that did their chemosensitivity, chemo, then proceeded to autologous transplant, and then they were planned to receive brentuximab. So these were highly selected patients based on unfavorable risk factors or if they were primary refractory disease. And the primary endpoint was progression-free survival. So this was brentuximab versus placebo, and we saw a progression-free survival difference in favor of the brentuximab arm. Likewise, the 2-year progression-free survival seemed to favor the brentuximab. All right. This was true based on any subgroup analysis, so whether they were primary refractory or had a high IPI score. So this is actually recommended for maintenance therapy after an autologous transplant in a high-risk Hodgkin's patient, which you'll hear about tomorrow in the stem cell transplant lecture. All right, what puzzles me as a clinician is what do I do with this information in a patient who has already received brentuximab in the A plus AVD regimen, because this study was conducted long before the Echelon trial was. All right, so clinically, I don't know how to interpret this, but if your patient had not yet received brentuximab, here's a very, very reasonable place to try it. Other agents you could use in relapse disease would be everolimus, lenalidomide, nivolumab, pembrolizumab, and some other chemo agents that I have detailed in your handout. However, we're not certain in what order we should be using these agents. So what I have here for you, the safety of using checkpoint inhibitors after brentuximab or transplant is somewhat undefined. All right, there's a concern of increasing the risk of pulmonary toxicity with checkpoint inhibitors after brentuximab. There's a concern about increasing a risk of GVH if you've had an allo transplant. So this slide here, I would say, is still to be determined. Right? All right, so I may be one of the first speakers to talk about survivorship. So we are so good at curing Hodgkin's lymphoma that now the long-term effects are probably our biggest problem. So things we should think about. These patients are at high risk for secondary cancers, especially lung or breast cancer, if they receive radiation to the neck or chest area. So in your handout, there are guidelines about when these patients should start screening for breast and lung cancer, which tests, at what interval, it's all in there. We would worry about cardiovascular disease and hypothyroidism, again, if the patients have received radiation to any of those organs. We're concerned about fertility issues, and obviously this is a younger patient population that may have a lot of adjustment disorders, so psychosocial counseling would be very important as well. All right, so a slide or two about nodular lymphocyte predominant Hodgkin's lymphoma. So again, this is kind of the outlier. There are some references that suggest this isn't even Hodgkin's. It's a completely separate disease state. So this is very rare. We do not know what the preferred chemo regimen is. We use ABVD because, hey, that's what we do for Hodgkin's. But some centers actually use CHOP because that's what we do for other types of lymphoma. So I think either of those are appropriate. I think the thing you're going to remember is that these patients tend to be CD20 positive. So you could use rituximab alone or combine it with either R-CHOP or R-ABVD. This is the one time you would select R-ABVD if that was presented to you as an option. The wrong answer is going to be brentuximab because these cells universally do not express the CD30 antigen. So brentuximab and all of its, newness in classical Hodgkin's lymphoma does not apply here. Okay, nice work, everybody, nice work. So the other supportive care issue I have in this module is extravasations. So the final audience response question. Our patient has just completed her ABVD infusions, and she comments that she feels some warmth and burning around her central line site. Since her infusions are completed, it's unclear which agent or agents may have extravasated. So how should you proceed with any antidotes? Would you A, treat the vinca alkaloid extravasation, B, treat the anthracycline extravasation, C, treat both the vinca alkaloid and the anthracycline extravasation, or D, treatment is not necessary since extravasation has not been definitively confirmed? I can feel how angry you guys are at me right now. You're like, what is that about, right? Like, what is she doing? All right, let's see here. Okay. Oh, interesting. So, I'm very glad nobody picked D, right? I think we all know that you would be very liable if you said, I don't think they really extravasated, right? So D, not an answer. All right, I would love to treat both the vinca and the anthracycline extravasation, but how are you going to do that, you guys? If you remember, their management is actually completely opposite in terms of temperature, right? Hot, cold. So I would love to do answer C, but you can't, all right? So the most appropriate answer here is actually answer B, all right? Anthracycline's bad for extravasation, right? If you have to choose, the anthracycline is actually the worst of the two. So anthracycline versus vinca, the more tissue damage will occur from the anthracycline, more surgeries, more necrosis. So if you've got to choose, you're going to lean towards the anthracycline. Okay? So anthracycline management, if you recall, you're going to stop the infusion, but in this case it's already over. You're going to use cold compresses, and the way you remember that, anthracyclines are red, they're very hot, you want to cool that off. All right. And there is an antidote for anthracycline extravasations called dexrazoxane. Good luck getting that. But again, that is the on-paper answer, dexrazoxane. For a vinca, if a patient extravasated a vinca and you were certain of that, you would turn it off. Then you would use warm compresses, and the antidote for that is hyaluronidase. All right. In the handout are many other suggestions like DMSO and what have you, but again, I think the point here is this is an oncologic emergency. You need to know what's the antidote and which temperature compress to use. And I also have in the handout detailed about how you would document that, who you would consult, and how you would essentially ensure that you did everything possible to manage this. So that is the end of our time together.